again, everyone out there. This is Adam Russo speaking to you from Change Talk LLC, a private psychotherapy practice out of Essex, Connecticut. Please know that today's presentation is for academic and entertainment purposes only and constitutes only a summary level perspective on today's topic. This presentation is meant to quantify and assess effective trauma treatments I have learned both in Trauma 840 and during my many years as a psychotherapist. Today, there are just way too many effective models to choose from when it comes to psychotherapeutic options for individuals with a history of either shock or developmental trauma exposure. Consequently, I would like to reinforce my belief that an effective therapist is both one that isn't limited by artificial and mechanical programmed interventions and is adaptable to situational and client needs. For that reason, we will examine influences on child development, followed by my favorite trauma interventions that include eye movement desensitization and reprocessing, prolonged exposure therapy, cognitive processing therapy, attachment theory, and interventions associated with polyvagal theory. I'll also quickly be discussing some reasons other effective trauma treatments won't be incorporated into my clinical integration as we investigate future best practices. Nice. As we segue into the overview of this presentation, I would like to say that despite a majority of this presentation being evidence-based research surrounding empirical research studies, it's important to highlight that I believe being an effective psychotherapist is just as much of an art as it is a science. This means that you can be the best academically proficient counselor or teacher, but yet fail to exhibit the investment, concern, understanding, and non-judgmental atmosphere that is required to simply initiate the healing process. Furthermore, assessments are sometimes only as accurate as our client's subjective inner experience and point of reference. This presentation will include how childhood trauma affects our values, long-term mental and physiological effects of untreated trauma exposure, associated effects of psychotherapy for trauma, description of eye movement desensitization and reprocessing, cognitive processing therapy, and prolonged exposure therapies, constructs of associated interventions, nature of attachment, role of assessment and EMDR, critiques of other models that are used, biblical worldview and application, emerging therapies and interventions, and of course, further resources.
You have nightmares? Every soldier has nightmares.
Only one who is ashamed of what he has done.
You have no idea what I have done.
With the enormous amount of controversy surrounding Tom Cruise these days, I am often leery towards using this video as an example of the singular point that any critical incident is either marginalized or exacerbated by our cultural perception towards those events. This means that our point of reference surrounding shameful acts is generally constructed by our surrounding or internal culture that we often derive as being threatening or regrettable. For those of you that haven't seen this movie, it shows the natural progression of a combat veteran that assimilates the culture and belief systems of his captors. I will sometimes be referring to the protagonist, Captain Nathan Algren, to help you better visualize the constructs of the material in this presentation. All right, in order to understand the contextual basis of how eye movement desensitization reprocessing works, we must first understand the culture surrounding what is shameful or threatening that assists in trauma-based pathology. It is believed that roughly half of children and adolescents in the United States have experienced a traumatic event in their lifetime. Young children who have experienced traumatic events are more likely than adults to ultimately develop post-traumatic stress disorder. And for those of you that don't know, PTSD is defined as when an individual lives through or witnesses an event in which he or she believes that there is a threat to life or physical integrity and safety and experiences fear, terror, or helplessness. As part of the assessment process associated with EMDR, it's also important to realize the physiological, developmental, and psychological risk factors that have the potentiality to become barriers for a therapist or care provider that encounters children that were exposed to either shock or developmental trauma. Even a provider working with adults should identify that frequently there are omitted or repressed traumatic critical incidents that influence a client's perspective or belief system. Here are some long-term consequences of youth childhood trauma. They include difficulty learning, decreased overall physical health, memory deficits, maladaptive social interactions and emotional connections, behavioral problems, stunted brain development, increased rates of alcohol abuse, like you see with Captain Algren, increased risk of heart disease, increased risk of mood disorders and suicide. A large component of EMDR surrounds what is called bilateral stimulation that stimulates brainwave activity in both hemispheres of the human brain. Many types of brain integration deficits arise from neurodevelopmental difficulties that stem from either childhood biology or adverse childhood events that release the stress hormone cortisol. Cortisol is considered the primary stress hormone that increases blood glucose levels, blood pressure, whereas activity in the immune system decreases and release of inflammatory substances in the body is contained. Longitudinal research studies have indicated that chronically impoverished households typically display heightened levels of the stress hormone cortisol in the residing children. It's common knowledge that back in 2013, with the most recent release of our Diagnostic Statistical Manual of Mental Disorders, that they voted not to include the diagnosis of complex PTSD due to our failure not to adequately define such a construct. Shock trauma, which is also known as traditional PTSD, may be conceptualized of usually occurring as the result of acts of violence, terrorism, natural disasters, and combat. PTSD has three main features of avoidance, re-experienced events, hyperarousal. Acute stress disorder likewise has similar time-limited features and may be a precursor to PTSD if left untreated. Many features of PTSD or ASD may include some of the following: sleep disturbance, anxiety, trauma intrusion, agitation, disassociation, and memory deficits. One of the reasons why I love working with children is that children have the potential towards resiliency. However, coping behaviors they develop are unlikely to be healthy or sustainable. The longer treatment is postponed, the more difficult returning to a normal developmental path is for the child. The passage of time alone does not resolve the damaging effects of trauma, it can actually make trauma worse. They call that peridisassociation that we'll go over later. Trauma should be treated timely and effectively using trauma-focused interventions such as EMDR. All right, let's give you something to chew on when it comes to a cultural perspective. Summarizing the perhaps stark difference of how childhood beliefs can exacerbate childhood trauma exposure, let's swiftly go back to Captain Algren and perhaps attempt to understand how his culture might have changed during his captivity in the movie. Starting out in the film, Captain Algren was an alcoholic that religiously followed the belief systems of the United States Army's Uniform Code of Military Justice, and likely the Protestant belief system. Captain Algren made several references supporting their statement, "You have no idea what I have done," that we heard throughout the video clip, which was later referenced in the movie as killing innocent women and children. Once in captivity, Captain Algren begins assimilating many of the samurai's ways, which include their own code of conduct, which is called Bushido, along with their Japanese support and acceptance of imperfection, which is known as wabi-sabi. Captain Algren then appears to be finding meaning and significance in their lives, while eventually fighting for a cause that he felt as worthy, the survival of the samurai culture. Please note, the Christian column is meant to be a general depiction of common knowledge Christian belief systems only. As examples of deviation from these Christian practices, the Knights Templars cherish the notion of waging a religious war in the name of God, along with today's extreme terrorist religious groups. Other extreme examples would include the much older Norse mythology that is believed that there was the highest form of heaven for the mightiest of warriors, called Valhalla. Since legal codes and insurance company reimbursement does not support the capture and imprisonment of our clients to force cultural immersion of perhaps a more forgiving belief system, I move into desensitization and reprocessing may perhaps be the next best thing. EMDR is the most distinguished evidence-based treatment approach for trauma-exposed children and adolescents. In fact, in 2013, the World Health Organization reported that trauma-focused CBT and EMDR are the only psychotherapies recommended for children, adolescents, and adults with PTSD. EMDR is defined as a treatment methodology used to reduce the emotional impact of trauma-based symptoms such as anxiety, nightmares, flashbacks, or intrusive thought processes. The EMDR model began one day when Dr. Francine Shapiro was walking next to a duck pond and began realizing that her eyes were moving back and forth, recalling a previous life memory. Originally named Eye Movement Desensitization in 1989, the title was changed to EMDR in 1991 to reflect the many cognitive changes and information processing components EMDR shares. When a person becomes upset or in duress, the brain has trouble processing the information as it would have normally. Traumatic events are viewed as sometimes becoming stuck in time and remain unprocessed. Through bilateral brain stimulation, EMDR helps process previous traumatic content and replaces such material with perhaps more realistic emotional memories. There are roughly 8 phases of treatment progression under the EMDR model. Phase 1, like any good clinician, getting background information from the client that goes towards treatment planning. Phase 2, preparation, which includes, but isn't limited to, issuing self-control strategies. Phase 3, the use of assessment, which includes the validity of cognition and subject units of distress scales. Phase 3 Bravo, reprocessing, which is that bilateral stimulation. Phase 4, desensitization, which includes identifying disturbing emotions and or sensations. All right, moving on to Phase 5, which is installation of more realistic and accurate beliefs for the client. Phase 6 is a body scan where the client looks for any tension or physiological responses inside of them. Phase 7 is closure, not just when it comes to processing a traumatic memory, but also the time constraints a clinician is given and how they have to wrap things up and come up with segues and visualization interventions to help the client move on. Phase 8 is reevaluation, which is using again those VOC and SUD scales. Phases 1 through 8, it's important to remember that EMDR is not meant to be a rigid linear process. If a client continues to show insufficient progress warranting the next stage of intervention, a provider may go back and reinitiate previous phases. As one of many examples, if a client is triggered during a session and no longer wishes to continue, that might warrant a provider towards jumping to phase 6 and 7 and perhaps during the next session discussing the associated trigger. The EMDR program may develop as the following. Participants are offered several weekly therapy sessions between once to twice a week frequency. Despite evidence suggesting up to 100% symptom recovery with clients in just 6 one-hour session treatments with clients of a single trauma event, assessment is an ongoing process with many variables influencing outcomes and the length of treatment. So it's important to highlight that likely EMDR could never have existed without the cognitive behavioral traditions of the past several decades. Some brief highlights of similarities between cognitive process, prolonged exposure, and EMDR therapies include that they utilize Socratic questioning. They offer clarifying questions. They evaluate through using objective evidence, offer standardized assessments. They challenge and highlight core beliefs within the client, and attempts to identify traumatic experiences within a client's history. Despite EMDR being the treatment of focus for this presentation and clinical integration, it's also important to highlight other effective treatment modalities that a clinician may want to draw upon once the EMDR phases have been completed. CPT, for instance, differs from EMDR slightly, considering that it is a highly structured program in which the client learns the skill of recognizing and challenging dysfunctional cognitions. In the traditional administration of CPT, the cognitive component is predominant, with the trauma account element consisting of 2 sessions that include writing about the traumatic event, reading it back to the therapist, and processing emotions. Therapists in this model focus their attention on the index event, which is the traumatic material causing the most distress for the client. CPT requires careful and timely diagnostic assessments and interviews that may not convey accurate subjective client information. Assessment consists of diagnostic interviews and self-reported measures with the client. A pre-screening of the patient's traumatic event and persistent symptoms are measured before undertaking the first session. Several brief PTSD checklists and depression scale inventory measures can be used to assess pre-treatment symptoms and can be utilized during treatment to monitor progress. One such assessment is the Ptsd Checklist, which is a 20-item self-reported tool that assesses the 20 DSM-5 symptoms of PTSD. The PCL5 has a variety of purposes, including identifying symptom variants during and after treatment, screening individuals for PTSD symptoms, and making a provisional PTSD diagnosis early in treatment. Cognitive distortions are theorized to impact trauma recovery and is addressed in EMDR through the installation process. A client's faulty belief system may include the belief that this world is predictable, orderly, fair, or just. This is a cognitive distortion that may impact trauma recovery that is part of a popular culture, such as Captain Ogren's, and is addressed during treatment. Limitations surrounding research on CPT surrounds a majority of sampling surrounding war veterans that may exhibit high rates of post-traumatic stress disorder. CPT can be viewed as highly structured and relies greatly on client organization, willingness, honesty, and cognitive capacity to be beneficial for the client. I'm not sure how many students here have a history of working with client populations. However, due to developmental stages, coping mechanisms, defense mechanisms, and habitual deceptiveness, client disinformation is not as rare as some providers believe. All right, let's talk about some considerations with prolonged exposure therapies. The role of the counselor appears to be more like that of an expert, with homework assignments being given out regularly. Prolonged exposure therapy may be viewed as a confrontational model, which may increase client turnover rates. From clinician's perspective, client congruency surrounding homework assignment completion may be limited. Remember, perhaps the most important intervention a therapist can make is ensuring that the client makes their next appointment. This may relate to client expectations, client comfort, and clinician flexibility. There's a great deal of variables a good provider must consider when selecting appropriate interventions for trauma-informed care. One such consideration includes if environmental or internal factors might increase the potentiality towards re-traumatizing a client. In fact, the American Psychological Association indicates that prolonged exposure therapy should have safeguards in place surrounding the personal safety, stabilization, and emotional regulation and life skills of a client before performing PE activities. Unlike prolonged exposure or highly structured cognitive processing therapy modalities, eye movement desensitization and reprocessing therapists encourage a client to focus only on parts of a memory for a short duration. Then the clinician will encourage the client to focus on whatever comes up during bilateral stimulation interventions, which follows the natural cadence of thought and conversation. Much like prolonged exposure in cognitive processing therapy modalities, an EMDR practitioner will make good use of standard client information gathering that will include open-ended and forced answer responses along with ongoing assessments throughout treatment. However, perhaps some unique hallmarks of EMDR include body scans, where the client makes note of any bodily sensations or physiological responses, bilateral stimulation, memory integration either through visual, tactile, or auditory responses, installation, supplementation of perhaps more constructive beliefs, and of course closure, either process previous interventions or use container stalling interventions to buy yourself some time. Socratic questioning is a therapy technique in which the therapist implements leading questions to assist the patient towards challenging the accuracy of their thinking and reconstructing inaccurate thought patterns in a way that alleviates psychological distress. There are 6 categories of Socratic questioning, which are clarification, probing assumptions, probing reasons and evidence, questioning viewpoints and perspectives, analyzing implications and consequences, and questions about the question. All right, well, I'm sure a few of you guys are actually curious about the photo on this page. This photo was taken inside of a chapel in the Connecticut State Veterans Home, a media care facility that I was at for a couple of years. Oh my God, when I say beautiful stained glass, it's amazing. Clients that seek out therapists often claim to experience an existential dilemma or a crisis of faith. Loneliness and isolation from others, including God, are common themes for survivors of trauma. In Psalms 34:4, it indicates, I sought the Lord and he heard me and delivered me from all my fears. Now, there is one thing I've noticed with the majority of my clients who are considered part of the LGBTQ community that have experienced trauma. I find that many of these clients often quote to me one of the brief sentences in the Old Testament, which is in Leviticus 18:22, where it states, You should not lie with a male as you would a woman. It is an abomination, and consequently appear to disregard the entire Bible due to this one passage. For good or for bad, I believe these situations sometimes instigate a crisis of faith that may be addressed with the client during treatment. CPT, EMDR, and PE assist in highlighting how a person's thoughts, beliefs, and attitudes affect their feelings and behaviors. This idea is supported by various biblical scriptures, such as Proverbs 23:7, which suggests, "For he is the kind of person who is always thinking about the cost. Eat and drink," he says to you, but his heart is not with you. In this theology, a caretaker is invested in the child's treatment process. The principle is suggested in Proverbs 22:6, which states, "Start children off in the way they should go, and even when they are old, they will not turn from it." The encouragement towards self-reliance for guidance and direction is inferred by these modalities. But according to Philippians 3:9, we shouldn't put our trust in ourselves as if we have a natural ability to do good. Our full trust and confidence should be with God alone. All right, briefly, we're going to talk about a common treatment modality used for trauma processing with various populations, which is trauma-focused cognitive behavioral therapy. TFCBT is a form of cognitive behavioral therapy that highlights on social cognitive theory of PTSD, repairing associated damage ensued by the event along with maladaptive belief systems. Cognitive behavioral therapy is considered a modality of psychotherapy that focuses on a person's thoughts, beliefs, and attitudes that affect their feelings and behaviors. It is viewed as the most distinguished evidence-based treatment approach for trauma-exposed children and adolescents. It recognizes that traumatized children have unique and varied emotional and behavioral difficulties. Like prolonged exposure, EMDR and cognitive processing therapy is considered a structural intervention. TFCBT allows for flexibility, involves multiple sources and treatment planning. Despite the growing efficacy, validity, and reliability of trauma-focused cognitive behavioral therapy and related models, there are emerging newer interventions and modalities that incorporate perhaps some of the best practices of most popular psychotherapeutic models. One such model, accelerated resolution therapy, or also known as ART, has gained a great deal more attention by the United States Department of Defense recently. Accelerated resolution therapy was first designed in 2008 by Lainey Rosenwitz, who's a licensed marriage and family therapist from West Hartford, Connecticut, which is right down the street from me. ART may be considered one of the most eclectic model borrowing theories and interventions that borrows from Gestalt, guided imagery, cognitive behavioral, and eye movement desensitization. Many clients find significant relief from their symptoms in 1 to 5 sessions with ART. The model has been researched by both the Department of Defense and the Veterans Administration, who indicate auxiliary uses such as veterans with symptoms of combat-related PTSD have a high prevalence of significant pain, including neuropathic pain. Brief treatment of symptoms of combat-related PTSD among veterans by use of ART appears to acutely reduce concomitant pain. More research is needed prior to ART's implementation. This theory was developed by Dr. Ronald Rudin, who believed symptoms arising from a traumatically encoded event can be produced by the release of stress hormones from continual and intermittent activation of an encoded memory, either by conscious or inadvertent recall. It is theorized that upon recall of a traumatic event, that memories become labile and has the potentiality to be de-encoded. It also generates delta wave brainwave activity between 0.5 and 4 Hz. Having intervention works by directing the tactile sensory trait to create electrocutical response through depotentiation of the AMPA receptors that are theorized to be pivotal in biological responses to traumatic events. Future research should focus on areas that may include the roles of comorbidities, such as concurrent depression, acute brain injuries, substance misuse, and sleep disorders. The potential consequence of moral injury, also known as the events that conflict with deeply held morals and beliefs, resulting from both shock and developmental trauma, and high rates of experiencing the aftermath of deaths of others. CPT might be beneficial to many military and non-military trauma survivors, as present studies are promising in that they are beginning to highlight military-afflicted patients seeking treatment in the community. An adaptation of the cognitive processing therapy is found in spiritually orientated cognitive processing therapy, SOCPT. SOCPT correlates maladaptive interpretations of trauma by focusing on gradual processing, exposure, and cognitive restructuring using spiritual resources, such as practices, scriptures, values, and motivations, to ultimately challenge maladaptive thinking patterns and deal with stuck points. Spiritually orientated cognitive processing therapy does not view cognitions related to guilt and shame as erroneous interpretations of trauma. Rather, SOCPT focuses as a reality within the broader society's cultural norms and moral context, which might require forgiveness and or confession of sin within the healing environment of the individual's faith community. Research which has explored religious CPT has helped in the design of SOCPT, including the necessity to approach certain stimulus response struggles on an individual capacity using cognitive methods, and other struggles by intervention in a healing faith community, social isolation, and lack of support. Exploration should also include longitudinal research considerations to maintain and extend the gains achieved during individual therapy. Spiritual involvement has been associated with quicker recovery from PTSD in observational studies. Thus, an individualized therapy capitalizes on spiritual resources to intentionally address the stimulus response, either spiritual or religious components, that has the potential to improve PTSD faster than a therapy that does not focus on these constructs. The result will be a stronger force and healthier clients who will make better citizens, workers, and family members. Cognitive processing therapy has four main components: psychoeducation surrounding PTSD and CPT, processing previous trauma, learning to challenge maladaptive thoughts surrounding said trauma, and trauma theme exploration. What to look for in a CBT therapist. Mental health practitioners can receive training and certification for CPT. Some organizations, such as university clinics, help provide training seminars and workshops in CPT. Additionally, several CPT treatment programs have been developed to assist clinicians in delivering the therapy. Education about PTSD and CPT. CPT starts with standard education surrounding PTSD and common reactions of how people respond to trauma. The therapist will then start treatment by asking about the symptoms a client is recently experiencing and explaining how CPT works, then discussing the goal of treatment. The most critical component of effective CPT for trauma includes ensuring the client learns about how the thoughts circumnavigating the trauma, oneself, the world, and along with others can affect emotions. Knowing the basics is a great place to start. CRAFT stands for Community Reinforcement and Family Training. Post-traumatic stress disorder is a web-based course for family members of veterans working to manage PTSD. This course teaches family members how to encourage their veteran to get treatment and support them during care. CRAFT PTSD also offers tools for family members to improve their own quality of life. Features include self-paced learning, so you can stop at any point and pick up where you left off at another time, exercises to help you review skills, and resources to protect you and your family, including tips to help you create a safety plan. Wrapping everything up, let's just say that traumatic occurrences have always been caused by and can be exacerbated by a myriad of influences, like peridisassociation, for instance. We as providers cannot limit ourselves to a single intervention or understanding while attempting to treat a client as a whole person and understanding the transient influences of mental health. Ultimately, it's through perhaps an eclectic lens via prolonged exposure, cognitive processing therapy, and eye movement desensitization reprocessing in a biblical narrative approach so that we can strive for our clients to not only be removed from pathology, but to thrive as individuals.